My name is Arishenkoff. I am an internist at Vancouver General Hospital and one of a dedicated group of POCUS faculty that is responsible for POCUS education for the UBC Internal Medicine program. This is a presentation on POCUS Fundamentals, designed to provide POCUS trainees with core scanning principles. This is meant to be a primer, in particular for learners preparing for hands-on workshops. The aim of this presentation is to provide the novice scanner with specific, tangible principles to focus on while building your POCUS skills. First, I think it makes sense to describe POCUS as it pertains to acute care medicine. From there, I will discuss a list of fundamental concepts that I have arrived at after years of learning and teaching POCUS. This is not an exhaustive list of POCUS skills, rather core principles that I think are important to drill down on, and if adhered to, will make you a better scanner and help ensure appropriate integration of POCUS data. These are good habits that should be acquired early on. I also review these fundamental concepts when doing train-the-trainer sessions with residents or faculty new to teaching POCUS, with the aim of providing them with specific high-yield principles to focus on. Point-of-care ultrasound is vast. It does not belong to a specific specialty and is constantly evolving. It is an invaluable tool in acute care medicine. I view it as an extension of the physical exam, not a standalone examination. A very relatable example of this is the incorrect assertion that the IVC is, in and of itself, a volume status assessment. POCUS is distinct in that it is performed by the clinician at the point of care. It allows the clinician to incorporate the information in real time with the benefit of an intimate knowledge of the clinical picture. POCUS is a limited, goal-directed exam designed to supplement clinical assessment, guide immediate management, and guide bedside procedures. Finally, it provides the opportunity to follow the patient status over time with repeat examinations. Learning point-of-care ultrasound isn't easy, but is definitely worth the investment. The reality is, like everything in clinical medicine, there are nuances and complexities at every turn. POCUS is no different. The clinical integration of point-of-care ultrasound requires considerable physical skill and clinical acumen in order to successfully acquire images, interpret the images, and integrate the images to make clinical decisions. Anyone that tells you different is likely sitting on the early part of the Dunning-Kruger curve. I'm not trying to discourage anyone from picking up the probe, just trying to emphasize the fact that like any aspect of medical training, it requires a great deal of practice and keen appreciation of potential pitfalls. I suggest that you should be wary of the POCUS trainee making claims about a patient's valves. In fact, you should be wary of claims about the IVC exam unless you are certain that the POCUS user has been diligently using ultrasound, in other words, multiple scans per week, for several months. From here, I will review a list of POCUS fundamentals. First, you need to plan the scan before bringing the machine to the bedside. Second, take time to set up for the exam. Third, there is not a single right way to hold the transducer, but there are wrong ways to hold the probe. Fourth, using external and internal landmarks to guide probe placement and probe movements. Fifth, utilizing windows and avoiding obstacles. Sixth, review the language of POCUS, including probe movements and anatomical planes, as well as a systematic approach to image optimization. POCUS Fundamentals number 1, create a plan. Incorporating POCUS must be done with a clear and defined purpose informed by the clinical context. In other words, don't go in blind. Ask yourself the following questions. First, what is the clinical problem? This will then inform what the question is that you're trying to answer. From there, you can determine what it is in particular that you're looking for. Then move on to what POCUS applications are indicated. And finally, consider whether there are confounders that will contaminate your interpretation. Going through this process will optimize your chance of uncovering the important findings. If you don't look for it, you will miss it. It helps prevent exam creep. It'll help you stay within your boundaries. Don't get distracted by things that are outside your skill set. If you are scanning above your skill level, you will cause problems. POCUS Fundamentals number 2, Setup. Now that you have a scanning plan, take time to set yourself up for success. It is important to be sure to choose the best probe, select the most appropriate preset, and reposition the patient. A quick word on presets. Many possible presets may be available and will vary from one machine to the next based on the request communicated to the vendor. Available presets also vary from one transducer to the next. For example, you will find that once you have activated the linear array transducer, a cardiac preset will not be available. In general, selecting the appropriate preset will provide a nice starting point for specific applications by reducing the need for additional manual adjustments. In addition, it provides access to applications, specific tools, calculators, and reporting forms. However, the right preset will not eliminate the need for fine adjustments to the image. You should still take time to optimize the image, including adjustments to gain and depth. In this image, a vascular preset is provided. Vascular scanning frequently utilizes Doppler functions, and therefore vascular presets will include access to Doppler. You will still need to consider whether the specific Doppler setup is appropriate for your needs. In particular, adjustments may be required depending on the velocity of flow that you are looking at. It is important to recognize that a given preset may not always be appropriate for your particular imaging needs. For example, lung presets are often configured to optimize the recognition of pleural sliding. This preset is not going to produce the best quality images for lung findings such as hepatization or pleural effusions. Selecting the correct tool for the job is crucial. You should have a basic understanding of the probe qualities to inform this decision. First, the curvilinear array transducer. It can be seen here on the far left of the image. It is a low-frequency transducer providing good depth of penetration. It has superior spatial resolution when compared to other common low-frequency transducer, the phased array. However, the spatial resolution is not as good as a high-frequency probe such as the linear array. It has a large footprint, providing comfortable contact and delivering a large field of view. It is excellent for scanning the abdomen and chest. The phased array transducer, which can be seen here in the middle, is also a low-frequency transducer. It has superior temporal resolution when compared to the curvilinear array transducer. Therefore, it is great for looking at moving objects. It is a sector image with the beam generated from crystals organized in the center of the transducer, producing a wide field of view in the far field. It is well configured to pass through narrow rib spaces while generating a broad image of deeper structures. However, the image in the superficial field is compromised. It is excellent for looking at moving structures, for example, the heart. It may be used in the abdomen and chest, however, the image quality generally is inferior to that of the curvilinear array transducer, especially in the superficial field. Next, the linear array transducer. It is seen here off the edge of the screen. It is a high-frequency transducer, providing excellent spatial resolution for superficial structures. The depth of penetration depends on the attenuation of surrounding tissue, but often starts degrading around 4 centimeters. It is important to take some time to get the patient into the right position. Poor patient positioning can contaminate the findings. For example, the patient on the left of the screen is in a terrible position to look for the JVP. In this image, the head is not in line with the body and will likely impact the IJ form. They need a boost. When scanning the lateral chest, ask the patient to tuck their hand behind their head, like the woman in the picture at the top of the slide. If you are having difficulty finding the heart in the parasternal location, ask the patient to roll into the left lateral decubitus position. If you are scanning the chest for a pleural effusion, placing the bed on an incline can help increase the size of the pocket in the dependent region of the chest. POCUS Fundamentals number 3, holding the transducer. There is not one right way to hold the probe, and grip may change depending on operator position and specific probe manipulation. I have definitely encountered many wrong ways to hold the probe. In general, the operator should, number 1, hold the probe low, like a pencil, for maximum control. Number 2, use fingers or the base of the hand to anchor the probe to the patient's skin in order to prevent drifting. The image on the right side of the screen shows excellent probe handling. Probe placement as well as probe movements should be deliberate with purpose and systematic. It must take into consideration the anatomy, presence of obstacles, and take advantage of sonographic-friendly windows. For example, consider the exam of a right IJ. The external landmark for the placement of the probe when looking for the IJ should take into consideration the location of the carotid artery, which is the internal landmark. Depending on the status of the CVP, the IJ may or may not be visible. I know if I lay the probe in the transverse plane just cephalad to the clavicle across the two heads of the sternocleidomastoid, the external landmark, I will be able to visualize the carotid every time. This can be seen in this image on the left side of the screen. I am going to place my probe across the two heads of the sternocleidomastoid, and I will always land on the carotid. Once I see the carotid, I will train my eyes just lateral and superior to the internal landmark to identify the IJ. This will make sure I don't get distracted by cysts in the thyroid or superficial vessels that may mimic the object of interest. If I don't see the IJ in the vicinity of the carotid, I know that it is not an issue with my location, and I can set up trying to figure out why the IJ isn't immediately visible. In addition, I can use the location of the internal landmark to guide my probe movements. If I see the carotid at the left edge of the screen, I know my next move has to be either to slide or rock my probe to the patient's right. If we look at this image on the right side of the slide, I can see the carotid artery right here. This is my internal landmark. If I train my eyes just superficial and maybe a little bit to the left, that is where I would expect to find the IJ, which can be visualized right here, just deep to the sternocleidomastoid muscle. Scanning Fundamentals number 5, windows and obstacles. The interface between soft tissue and gas or air and bones or stones creates a highly reflective surface at which no beam energy can penetrate. Any structures deep to that will be in the shadow of the interface and will not be visualized. For example, the air-filled bowel is a substantial obstacle interfering with the visualization of posterior abdominal structures such as the IVC. In order to visualize the structures obscured by obstacles, the operator should utilize windows to access the object of interest. For example, the liver is an excellent window that allows the beam to penetrate through the abdominal cavity to visualize the posterior vena cava. In this image here on the left, we can see a soft tissue air interface that creates dirty shadowing and beam attenuation, and we don't see anything deep to the bowel. Over here on the image on the right, we get a look at the very uniform structure of the liver. The liver is a fantastic window that will allow our beam to penetrate beyond the abdominal wall and be carried deep into the abdomen, where we will be able to visualize the IVC. Scanning Fundamentals, number 6, Transducer Movements, Anatomical Planes, and Image Manipulation. Scanning is largely a game of millimeters. Big jerky movements should be avoided. Fine motor skills must be developed. The scanner needs full control of the transducer, allowing for only one of the cardinal probe movements at a time. If you are unable to prevent the probe from fanning while you are rocking, you will quickly become disoriented. This is an image from a study where the investigators were able to track the movements of novice scanners compared to experts. The novice scanners covered substantially more area, much of which was not fruitful.
By convention, the body is divided into sagittal, transverse, and coronal planes. It is important to be able to remain oriented in space and understand how to manipulate the transducer to survey the area of interest in each of these planes. The image on the left shows the 3 standard planes of the body and how they relate to the kidney. In this example, consider the kidney as if the patient were supine, with the head oriented towards the top of the screen. In this case, we have the right kidney with the anterior surface visible as if you were able to see through the anterior wall. Up here would be towards the head or the cephalad direction, and this is the superior pole of the kidney. And down here, in the caudal direction, is the inferior pole of the kidney. Slicing in a vertical fashion, we have the sagittal plane. Here in the horizontal plane, we refer to this as the transverse plane. And within the plane of the screen, we have the coronal plane. The transverse plane produces a short axis view of the kidney. Notice how a short axis view of the kidney can be produced by rotating the transducer 90 degrees from a sagittal plane and a coronal plane. Here is the transverse view of the kidney. The sagittal plane and coronal plane produce a long axis view of the kidney. Both of these views include a portion of the wall of the superior pole, the cephalad direction, and inferior pole, or the caudal direction. However, the coronal view includes a portion of the lateral wall and medial wall, while the sagittal plane contains a portion of the posterior wall and anterior wall. Here we have a long axis view of the kidney in the sagittal plane. Notice how the superior pole is up here, and the inferior pole would be down in this direction. You can think about this view of the kidney as if we had sliced of the kidney here in the long axis, opened it up like a book, and we're looking at the right portion of the kidney, or the medial half of the kidney, head on. In that case, the anterior wall is over here, and the posterior wall is over here on the left. Compare that to the coronal plane, where again we have the superior pole up here, the inferior pole at the bottom. But in this case, we're looking at the lateral and medial walls as the beam slices through the kidney in the coronal plane, rather than the posterior and anterior walls. There should be no random movements with the transducer. It is important that the sonographer understands the effect that each of the cardinal movements will have on the image. Probe movements should be deliberate and sequential to maximize efficiency and minimize frustration. Let's start with rotation. This movement is pretty straightforward. It allows the sonographer to transition from a short axis view to a long axis view and vice versa. In the image here on the left, we can come back to the kidney, where once again we see that the sagittal plane gives us a long axis cut of the kidney. If we rotate 90 degrees, it puts us into a transverse plane. In that case, we go from a long axis view of the kidney to a short axis view of the kidney. It is a corrective maneuver in situations where the beam is off axis. The key is recognizing the error. The image in the middle of the screen is an oblique off-axis view of the IVC. You can see here that we start in the anterior aspect of the abdomen. We traverse through the liver, and as we get to the posterior abdomen, we see this ovoid structure here that is anechoic and in a location where we would expect to find the IVC. However, it does not appear to be either a long axis view where the IVC would be stretched out across the screen, or a more ovoid or circular short axis view if we were in the transverse plane. The cartoon on the right of the screen demonstrates the oblique imaging axis through a tubular structure. This plane here, through a tubular IVC, would give us the same type of form. To correct for this and obtain a true long axis view of the IVC, the corrective movement is a clockwise rotation, moving in this direction. If a short axis view was desired, the corrective movement should be a counterclockwise rotation, or in this direction, to give us a true short axis view. This would give us a more circular or ovoid form of the IVC. Fanning involves tilting the transducer over the short dimension of the transducer footprint at a fixed point. In general, this probe movement can be used to survey the cross-sectional anatomy of the object of interest. Let's start with the sagittal plane. By convention, the transducer marker will be oriented towards the patient's head or towards the superior pole of the kidney. And the beam will pass through the organ in the long axis. If we were to slice through the kidney with a knife and then look at it head on, it would look like the image in the middle of the screen. The ultrasound image is oriented based on the image marker as well as the time of flight. In the sagittal plane, the beam will strike the anterior surface of the kidney first. The anterior surface can be seen here. This will then appear closest to the top of the screen. The transducer marker is oriented towards the superior pole of the kidney. The transducer marker corresponds to the image marker. The radiology convention is to have the image marker on the left side of the screen. The image marker would be located here. Therefore, the superior pole will be found on the left side of the screen, and the inferior pole will be on the right side of the screen. Superior pole here on the left, because the transducer marker is oriented towards the superior pole, and that corresponds to the image marker, and therefore the inferior pole would be here on the right side of the screen. In the sagittal plane, a fanning motion will either direct the beam toward the lateral aspect of the kidney, or in this direction, or to the medial aspect of the kidney, directing the beam over in this direction. Therefore, fanning would result in sequential long axis cuts through the kidney from one side to the next. Now consider if the transducer was rotated 90 degrees to get a short axis. Fanning in a cephalad direction would produce sequential short axis views through the kidney towards the superior pole. Rocking the transducer is a tilting motion along the long dimension of the transducer footprint at a fixed point. In general, this movement can be used to bring the object of interest from one side of the screen to the other, or access a portion of the object of interest that is hanging off of the screen. Again, in the sagittal and coronal plane, we could rock the transducer in a cephalad direction or caudal direction. And in the transverse plane, we could rock the transducer towards the patient's right or laterally, or to the patient's left, medially. The middle image shows the beam passing through the superior pole of the kidney, superior pole up here. Note that the most superior aspect of the kidney is in the middle of the beam or the middle of the image, and the inferior pole is not even visualized. The beam does not pass through the inferior pole. By rocking the transducer in a caudal direction, the beam accesses the entire length of the kidney. The entire length of the kidney now is within the path of the beam. The superior portion of the kidney shifts from the middle of the image to the far left of the image. In addition, we can now see the inferior pole of the kidney on the screen, whereas before it was sitting outside of the beam. Sliding refers to moving the transducer across the skin. It may be moved in a cephalad direction or caudal direction to the patient's right or left, medial or lateral. It is often used to change locations or get around obstacles that may be superficial to the object of interest. Compression, or the final cardinal movement, refers to pushing the transducer into tissue. This may be used to improve contact, minimize the distance that the beam has to travel, especially if there is a lot of soft tissue to traverse, or assess for compressibility of an object. For example, in a DVT scan, a vein should be compressible. If it isn't, there may be a clot present. In conclusion, build a strong foundation, develop good habits. Being diligent about the fundamental skills that we discussed here will go a long way to making you a better scanner. Second, point-of-care ultrasound is but an extension of the assessment. It cannot be used to make clinical decisions on its own. Third, take the time to set up for the exam. It will pay dividends. Finally, there are no random movements in ultrasound. You must use landmarks and small, controlled probe movements, one at a time in a systematic fashion to optimize your image. Keep practicing. It is worth the investment.